Hi, everyone. I just wanted to do a quick video taking up some of the portions of the military report. For those of you that are in my class, my long-term care course, you will have just read this and completed a short assignment. And I thought it would also be beneficial to open it up to not only highlight some of the parts that maybe you may have missed when reading it the first time around, but also to my broader long-term care community who might not have actually had a chance to review these reports because they weren't necessarily widely read. They were widely reported on in the media for sure, but I don't know how many people actually have seen the reports and read them. So I'm going to share my screen so you can see the report and some of the notes that I've taken, and I'll kind of walk you through it. So let me just do that. If I can figure out how to share a screen. Okay, here we go. So the military report. This is it. It is a total of 15 pages. Where to start? Well, the report was actually finalized, completed May 14th, 2020. The military had been in 5 Ontarian long-term care homes, 4 of which were for-profit, I'd like to remind everyone, beginning April 28th, 2020. So they were in there for about 2 weeks before feeling the need to expedite this report. Because they were called upon due to the urgent and immediate need for personnel, and I highlighted these sections here, to provide humanitarian relief and medical support. So what I think was really a go-to to point out from the brigadier who wrote this initial report was that they wanted to make sure that these observations do not go unnoticed and did not go unnoticed because they were sufficiently serious to really hit home to the public that not only did the province of Ontario need to be informed, but the federal government, but it was something that effectively the media also needed to really get out there and kind of blow the whistle on what was happening in these 5 homes that they were deployed to. And keep in mind, many homes were in a similar state of peril at the start of the pandemic, but they could only go to so many homes. And these homes were the 5 chosen as, and who made those decisions to send them to those 5 homes versus a wider range of homes. We'll never know. But I would put a lot of money, I'd stake all my chips on a vast majority of homes having similar conditions reported, if indeed the military were there to conduct reports like the one we are overviewing right now. We will be overviewing. So let's scroll down here. This is the Brigadier General who effectively put this all together. These are the 5 homes that were included in the report. Eatonville Care Centre, for-profit. Hawthorne Place Care Centre, for-profit. Orchard Villa, for-profit. Altamont, for-profit. And then the 1 not-for-profit home, Holland Christian Grace Manor. So these are the 5 homes, and how they break it down is they look at each home individually. So the first home on the list, Eatonville Care Centre. I'm just going to read some of the highlights from this report. Of course, you have it here. You can read more, and you have read it more in depth. But for people who are not in my course and did not read this, I'll overview some of the key points that at least I want to make sure I leave you with. Number 1, infection control. Largely absent in these facilities. I would argue many facilities at that point. COVID-19 positive residents allowed to wander, right, in areas and in rooms of COVID negative residents, which would then lead to transmission. PPE is not possible, just not possible. Out the window, not possible. The reusing of supplies, very dangerous to do this. One example being a catheter pulled out and on the floor for an undetermined amount of time. You can imagine the risk of infections that come with reusing supplies like this in that capacity. Poor palliative care standards, that's end of life. supports, inadequate dosing of medications. I mean, people were suffering without proper medications at the end of their life. So just that's effectively what that is telling you. No mouth or eye care order supplies for palliative residents. So, just adding insult into injury for these people at the end of their life who just happen to be in these facilities at this horrific time. Poor Folly catheter care. Just at this home, a senior nursing officer in the military reported significant incidents of excessive sediment or abnormal discharge and bleeding with no follow-on action. So that's a very serious medical failure. CAF have found nearly a dozen incidents of bleeding fungal infections. Imagine if you had a fungal infection that got so bad that we're at the point of bleeding. Okay, imagine how harmful and painful that is for these residents. Supplies, general culture of fear, and we hear this repeatedly, to use supplies because they cost money. Because they cost money, okay? And it's not lost on me and many other people who have come out very adamantly against for-profit long-term care having no place in our long-term care sector writ large, is that during this same time, there are additional reports of these large for-profit chains, some of the largest ones, doling out hundreds of millions of dollars in shareholder revenues and profits during the same time that residents were suffering and dying without appropriate supplies because there was a general culture of not using them because they cost money, which would then, cut into profit accumulation for owners and shareholders, if you're going to follow that train of thought, right? So much so that key supplies were often under lock and key, not accessible by those actually on the floor, requiring them for their work. One example being wipes for PSWs, expired medications. That's great. Soaker pads. So in long-term care, there is, of course, a lot of residents, older adults, who have issues with incontinence, which means, and I warned everyone about this takeaway for an exam, because everything I'm saying today could be on an exam. It is not good form to use the word diapers for older adults. And I know you're going to see later on in this report, there actually is a mention of that, which was very bad form. But incontinence briefs or pads, that's what we call the supplies for people with incontinence issues with their bowels that require those, adult soaker pads, incontinence pads, when you can't make it to the washroom in time effectively and you don't have support to go to the washroom. You need to wear these incontinence briefs or pads as a backup. And unfortunately, when you didn't have enough of those supplies, oftentimes we hear of the beds of these residents being soaked through. And that is obviously very dangerous and can lead to other infections. And we have clear evidence here that these staff were not permitted to have extra soaker pads or towels for these poor individuals in their beds to help protect from these instances of soiling. And PSWs are noted as being afraid for their jobs on this issue. Afraid for your job if you, heaven forbid, seek the supplies required to do your job. Wrap your head around that. Cohorting of residents, as we've talked about with my students in previous lectures, that is separating sick from healthy residents and having the mechanisms to do that. We have it cited here, ministry requirements cited as reason they still have negative residents rooming with positive residents. So obviously that is, a massive infection prevention and control IPAC failure. If you have sick residents roomed with healthy residents, it's just a matter of time before all the residents in that room are sick. And we know, and you all know from our previous lectures, that most of the for-profit homes had an issue with ward rooms, right? So often for residents in one room. So you can just imagine that the second one person is sick with COVID-19 and kept in that room, everyone else is going to get the virus. It's just a matter of time, especially with the issue of insufficient supplies and PPE being provided to the workers to do their job safely. Let's scroll up. Communication. PSWs can be task-focused and do not always report discovered abnormalities to registered staff, which is also indicative of these workers being overworked and having too many individuals tasked for their care. So the poor staff-to-resident ratios leads to a situation where they're so overly task-focused and busy that they don't have the time, frankly, to report important abnormalities to the registered nursing staff on site. Information on long-term care, COVID status, residents and staff not available or updated. That's great. Management unable to effectively enforce restrictions on use of CAF PPE, so the military personal protective equipment. Staffing, massive staffing issues, as you can imagine. New staff being brought onto the facility that are not trained or oriented during the most dangerous time. Okay, so it's one thing you should never have workers coming into work in one of the most vulnerable congregate care living situations without sufficient training or orientation. And you are actively doing that during the worst possible time because of the severe staffing shortages across all levels, which, as you can imagine, leads to horrific morale among the staff. Many are overworked, burnt out, no time for themselves, working for, haven't seen their family for weeks. Importantly, doctors, MDs, were not present and had to be accessed by phone. So they phoned it in, which is not great, significantly, especially in this particular home. The staffing is such that it is impossible to provide care at a pace that is appropriate to each resident. I mean, just blatant failure in black and white. Get ready for this one. The staff report not having witnessed any psychosocial support for these residents who have all of a sudden had their families taken away. And as you remember from my previous lectures, and for anyone in watching this that has paid attention to my advocacy, the first thing I started really speaking up about was the dangers of cutting family out. Just all of a sudden deeming them non-essential visitors and blocking them from accessing their loved ones in these facilities, because I knew how not only dangerous it would be from providing that critical eyes and ears for these workers and for these residents to help protect their safety, whistleblower where appropriate, but also because most of these residents are then just left in their rooms alone, no one to talk to at a very scary time where many of them are sick and suffering without proper supplies and staffing. You can imagine the deadly psychosocial impacts of that. Indeed, I have said multiple times in multiple interviews, and you will see this later on in our course, that isolation kills, period, right? If you remember being isolated in your own experience during the pandemic, imagine also being sick at the end of your life without anyone around to help you, or certainly not enough people around to help you, and not being able to contact your family. So as you can imagine, the military reported these documents and instances where it's heartbreaking to get a report about someone who is agitated and difficult, in quotations, and has been getting narcotics or benzodiazepines to sedate them. But when you talk to them, they just say they're scared and feel alone, like they're in jail. I get emotional every time I read that. These are people who were scared and dying and sick. And instead of connecting them with their families and being there for them and making sure they had enough workers to support them, they were being chemically restrained. And chemical restraint is a term for effectively giving people these narcotics, these sedatives, to placate them, to quiet them, instead of providing the care and the support that they need. That in and of itself should horrify you. Moving on, so I don't keep crying. Gross inadherence to some recurring orders. In some cases, PSWs are reported to asking the military members not to do this task, whatever it may be, because it may, quote unquote, wake up the resident. If you think this isn't all abusive enough, wait till you see this. A CAF member has witnessed aggressive behavior, which ACC staff assessed as abusive and inappropriate. So they're openly documenting abusive and inappropriate behavior towards the residents during this time. Examples include aggressiveness when changing incontinence products, not stopping or slowing when residents complain of pain, pulling residents, aggressive transfers, impacting their resident ability to participate in care as able, for example, to roll themselves in bed, degrading or inappropriate comments directed at residents. Wrap your head around that. And this is documented, by the way, in plain sight. So people would often say to me and ask me in interviews, and media would even say this too, right? What's happening when the military's not there? What's happening in all the other homes where nobody was there actively watching and paying attention? This kind of abusive behavior was done in plain sight with people literally looking over your shoulder, documenting it. And there wasn't even the self-correcting function at that point by some of these workers to actually not behave abusively towards these residents. So, yeah. And wrapping up this particular home, reports of inaccurate charting or documentation. So this is effectively fraudulent charting, which is against the long-term care legislation. It's against the law. So they have documented reports of inaccurate charting or documentation being amended by agency staff following submission regarding patients' pain levels, nutrition, eating status. For example, they also reported inaccurate reporting regarding resident status to family. So family were being provided incorrect information around feeding, pain levels, their general condition. I mean, in plain sight, this is happening and being documented. The next home, Hawthorne Place. So again, numerous issues with infection control. This particular home had fans blowing in the hallways, which was a known factor that would increase the spread of COVID-19. So that wasn't great. Again, poor training and adherence to IPAC protocols, significant deterioration of cleanliness standards throughout long-term care at a time when cleanliness and sanitation is arguably more important than ever before. Little to no disinfection, insect infestations in the facility, ants and cockroach infestations, openly documented by the military personnel. Delayed changing of soiled residents, so the incontinence briefs I had talked about. When you don't change those, and people are left in, as you can imagine, their soiled pads, it leads to skin infections and skin breakdown. And that was clearly documented, which then can lead to infections, some of which can become deadly. So not for nothing, these have serious implications for residents' health. Standards of practice. Again, we see some more abusive behavior here, forceful and aggressive transfers of residents, often off and on their beds, for example. That's what we mean when you're transferring residents. Little to no regular turning of patients. So if people that are bedbound, a lot of these older adults are bedbound, they've lost significant mobility and they have trouble moving themselves. They might even be, some of them might be paralyzed. You have to move these people. You have to help move them so that they don't develop pressure ulcers, because that's what happens if you're just lying in one place for too long. Mobility is very important, right? Not just, losing of muscle mass, but also the development of pressure ulcers. And these pressure ulcers, I will show you in later lectures, actually have gone in some instances to become gangrene, and people have died as a result. So this is a serious issue. It's not just like, oh, if you leave them, in one position, it's okay. It's just uncomfortable. No. It is medically dangerous and has led to deaths. When these ulcers get out of control, they have led to deaths. And I have stories I will show you in subsequent lectures of this happening over the past few years. Forceful feeding observed by staff causing audible choking and aspiration. Same thing with hydration, forceful hydration causing audible choking and aspiration. One thing I have talked about, but I'll reiterate, older adults often have difficulty chewing and swallowing. They take longer to eat and swallow. So and if you watch me eat, I look like an animal. I eat very quickly. I'm like a snake. It goes right down. I don't chew often. I joke about it. But this is the complete opposite for older adults who are losing that functioning. So they actually require significantly more time to safely chew and literally drink. Okay? Because if you don't provide them that time, we know that it leads to choking and aspiration. which, as you can imagine, leads to deaths. Patients observed crying for help with staff not responding for extended periods of time. Narcotics not considered a high alert medication at that time in this particular home. So there was a high risk of dosing error. Activities of daily living, staff report residents not being bathed for several weeks. I heard this a lot in many homes, not just this home. DNR status not posted. Feeding status not posted. So if staff are coming in and aren't trained and being oriented, they don't have proper information for how to handle these particular instances of do not resuscitate, where someone is actively, let's say, choking or dying or needing CPR. They don't know what to do. And often residents have a clear plan for how they want that situation to unfold. So if that information isn't posted and staff don't know what to do, what do? Right? Scroll up here. Regular wellness checks, suboptimal, to put it nicely. Hours between wellness checks, the day or night shift. One reported incident of enteral feed tube not being changed for so long that the contents had become foul and coagulated. Okay. One incident of a permanent catheter being in situ inside a person for 3 weeks beyond the scheduled change date. That is wildly dangerous. Staff report significant lack of appropriate wound care. So wounds, if they have a pressure ulcer or some other form of wound, when they're not treated properly, because of things like here we're seeing shortage of supplies, lack of documentation, non-sterile techniques, no packing or improper packing, it leads to advanced stages of these wounds, often to the point where they can't be treated. And we have seen people die from this incident, these kinds of incidents in the sector across. Wound care supplies insufficient or locked away. Again, we're seeing supplies are being locked away. No crash cart available. Linen shortage noted. Shortage led to residents sleeping on beds with no linen, leading to increased skin breakdown. Completely preventable. Completely preventable injuries because they felt the need not to provide appropriate linens and supplies to these workers. Heaven forbid it get in the way of profits, right? Poor communication between shifts or lack of handover at shift change led to resident care aspects being missed. Sometimes, and this is against the long-term care law, no RN in the building other than an SNO during weekends. SNO and executive director, also an RN, only RNs on site on numerous occasions during the week. Significant resultant safety concerns regarding patient ratios. One nurse was responsible for up to 200 patients at this facility, as documented by the military personnel. Little to no orientation for new staff. Yet again, we see this. Staff disappeared and leave the floor unattended. Okay. PSWs often rushed and leave food on a table, but patients often cannot reach or feed themselves. Therefore, they're missing meals or do not receive meals for hours on end. Public interprofessional disputes amongst agency and permanent staff. So there was fighting between the staff that was clearly on display for everyone to see. And we'll talk about the issues with agency staff. We talked about it a little bit, but we'll talk more about it in future lectures and why it causes clear antagonisms between the in-house staff, who then often have to retrain them and do more work because these people are coming in and bouncing around at different facilities and don't know the residents, don't know where the supplies are. And it takes more time and effort away from the care of residents who should be receiving that care to then have to train agency workers who, to add insult to injury, are coming in and being paid sometimes 2 to 3 times more than the in-house workers who are having to do the clear vast majority of the work. So then you wonder why there was clear fights between the permanent staff and the agency staff. All right. Third home, Orchard Villa. Nightmare. And you've been reminded of this, but I'm going to remind everyone else who is not in the course and maybe watching this, we will be having a special film screening of Stolen Time, March 5th, 2025. So that's just a few weeks away. And the person featured in that documentary, Melissa Miller, is a lawyer. She's representing a lot of these Orchard Villa families. And we did a lot of advocacy together during the pandemic. You'll see some of those interviews. But if you want to learn more about her experiences and what she knows from currently representing a lot of these families at Orchard Villa, come out to that event. It'll be eye-opening. Orchard Villa, Pickering. Lack of clear infection control issues here, lack of cleanliness, cockroaches and flies present, rotten food smell noted from the hallway outside patients' rooms, inappropriate PPE use noted throughout all staffing levels, poor IPAC/PPE practices. And obviously, when you have these kinds of errors, it leads to increased outbreaks. And this home had one of the largest number of fatalities and most devastating outbreaks. Patients being left in soil. This is where I said they had diapers. Big no-no. So, of course, these are military. They're not necessarily experts in the, vernacular around aging and, some terms that are not great. So we do not say diapers. So ignore that. Incontinence pads or briefs is what you should be saying. Patients being left in beds soiled in their diapers rather than being ambulated, which is another word for taken to the washroom, the toilet, because there wasn't enough staff to take them to the actual toilets because they needed assistance. They had clear mobility issues, right? Mouth care and hydration schedules not being adhered to, lack of proper positioning. And this is the most egregious point I have to hit home for this facility. Because they didn't properly position individuals, often at meal times, meaning sitting them up straight, a resident actually choked, and it appeared to have contributed in their death. Okay, completely preventable. You can ask Melissa about this in particular. If you come to our event, there'll be a Q&A period. So feel free to ask her about that. Respecting dignity of patients, not always a priority. Caregiver burnout among the staff clearly noted. Unsafe nursing medication. You saw a video too of some of the workers whistleblowing in previous lectures about this particular home. So now you're seeing it in black and white, right? Staff putting food and important belongings outside of residents' reach. Yet again, we're hearing these similar issues. And obviously the residents who have clear mobility issues can't reach the food for themselves. So they just don't eat, and they didn't eat. And I heard stories, and this has been widely reported, of when family finally were allowed in. And it took us about 6 months to get them in, fighting every day. We would hear people tell us how they're, and my research with Dr. Charlene Chu also reiterates this in our papers, looking like quote unquote skeletons, having lost somewhere upwards of 20, 30 pounds during just that 6-month period. They looked unrecognizable. And now you understand why, right? Because of situations like this. Get ready for this. Incident of likely fractured hip not addressed by a staff. Fractured hips can lead to deaths for these older adults. Not to mention, one of the most painful things you'll ever experience. The fact that it wasn't addressed or treated, and this person wasn't sent, properly to the hospital when they should have been, is such egregious failure. I don't have enough words, right? All of it, I don't have enough words. Multiple falls. So here's another thing to reiterate. Older adults are very frail. A fall among a resident can lead to death, not just a fractured hip or bone. It can lead to death, right? So it is very dangerous if you are not properly acknowledging and preventing falls, right? Falls prevention is one of the top priorities in these facilities, and clearly it wasn't happening. Multiple falls without required assessments following the fall. So we were even following up on these people to see what they needed and what kind of care. Obviously, oftentimes, hospital care wasn't being provided to these people. Multiple scenarios, this is so abusive, of walking aids being removed or mattresses set on the floor as patients were unable to stand from that low position. So to effectively keep them locked in their rooms and prevent them from wandering. That is restraint, okay? That is abusive, it's restraint. It is undignified to a level that I have never heard of before. Right? So clearly put on display for people to read. Again, issues with supplies. Again, patients sleeping on bare mattresses because of lack of access to the laundry linens. Get out of here. Ambiguity on local practices, incident reporting channels locked, staff unable to report anything other than medication errors. What about all the other things that are going on in the home? It's just not being documented, apparently. Communication, no communication between PSWs and RNs, RPNs, that patients are choking with meals or unable to chew, swallow. No communication about that. Poor communication between facility management and housekeeping. So patients being moved into rooms that have not been cleaned due to miscommunication. What? Staffing, lack of training for new agency staff. No surprise. Nursing staff unsure where or how to document status changes, how to change medication. So these, agency nurses are coming in and they did not know how to do basic elements of their job because there wasn't enough communication. There wasn't enough information for them to know how to do this, right? No accountability for staff in regards to upholding basic care needs or best practices. Are you joking? Let's go to Altamont. Inadequate nutrition due to significant staffing issues. Most residents reported not having received 3 meals per day. Here we go again. Significant number of residents have pressure ulcers, stage 2, 3, and 4, and unstageable as a result of prolonged bed rest, right? Because they weren't being ambulated, they weren't being repositioned because there wasn't enough staff. Certainly they weren't even being taken out for walks, helping them to move. Moving is important. We need to move as individuals. When you don't have the assistance to ambulate, this is what happens, right? Wound care nurses that were supposed to be scheduling every week were not coming in for weeks on end, resulting in significant deterioration of said wounds, calcipries. Residents had been in bed bound for several weeks. At the time of the military arriving, many of the residents had been bed bound for several weeks. Wrap your head around that. And this one makes me so upset every time. Oh, I can tell I'm going to cry again. A nonverbal resident, imagine if you can't speak, wrote a disturbing letter alleging neglect and abuse by a PSW. The letter was handed to one of the military personnel by the resident and was immediately brought to the attention of management. Note, this was handled immediately by the management team. How long was that abuse happening? What happened to this poor person who couldn't speak? One of the most vulnerable people without a voice, literally being abused. And they had to sneak a letter to the military member. Imagine if that was your loved one. Imagine if that was your loved one. Serenity now. Multiple issues here about unsafe, significant concerns regarding agency staff clinical skills. So you can read all of those. Obviously, these have direct implications on resident well-being and safety. Still on Altamont here, insufficient wound care materials. Residents have no way to receive additional personal supplies because if they're getting them from family members who bring this in often, they can't get that stuff anymore because family were locked out for 6 months. Long-term care facility had no accurate nominal role as to resident room and bed locations. That's great. Evening shift unstable. Often no PSWs are present after 2:30 p.m. PSW ratio, often 1 per wing. So 1 worker for 30 to 40 plus residents. That's dangerous. Unverified reports of only 2 PSWs within the facility during ACC rest days. So when the military were not there for a day, apparently there was unverified reports. They were being told that there was only 2 PSWs in the entire facility. What? Regular arguments between staff observed with derogatory language. So more arguments. They are rushing patients, not respecting their pace, and have observed making degrading or inappropriate comments directed at residents, more abusive behavior being documented. Kitchen staff do not attend to the snack cart during night shift, and nursing staff are forbidden from entering the kitchen, so residents go hungry. That's lovely. Let's go to the last home here. Holland Christian Homes. So again, staff moving from COVID positive units to other units without changing contaminated PPE, which obviously increases the risk of transmission among the COVID positive residents and the units to the COVID negative units. Some staff, so it doesn't sound as worse as the other homes, not following IPAC policies. Again, concerns about agency staff, and we will talk about this more in future lectures. We've talked about it a bit already, but we'll resume. But just more evidence here. Concerns about agency staff leaving food in a resident's mouth while they're sleeping, clear choking hazard. Aggressively repositioning a resident. Improper use of lifts, not assisting residents during meals. Staff would rather write the resident refuse to eat rather than helping them eat. In plain sight, this is happening by agency workers brought into these facilities from temp agencies. Wrap your head around that. Okay, that's it. So I hope you are as shocked and disgusted, frankly, as I was. And you took a lot from reading those reports. And for those who were not in my class and did not read the reports in full, but I'm sharing this with, and you're seeing it just from being part of the long-term care community. I hope that refreshes your memory about just how terrible things were. And it's a stretch to say that things have improved perfectly or even appreciably. And I will show you throughout the remainder of this course that indeed things did not necessarily get better, and new policies and regulations and laws have been amended to actually enable more negligence and more abuse in these facilities, which is mind-blowing to actually think about. But that's the reality, specifically here in Ontario. So I hope you learned a lot from that. As usual, I'm always here if you have questions for me, but I thought this would be a helpful little recap video for those of you who are reading it without me, maybe explaining some of these terms and being able to provide a little more context. So I hope you enjoyed this, as depressing as it is. And I'm here for any questions. Have a wonderful, non-traumatizing day, everyone.